Thanks, Dr. Rini, for a wonderful introduction. My name is Lorenzo, and I'm an assistant professor in the Department of Neurology at UCSF. And as Dr. Rini said, I'm a social and affective neuroscientist conducting primary neuroimaging research in older adults to study those brain circuits that are important to sustain emotions and well-being. And recently also I've been collaborating with our division that conducts studies with Schedule 1 substances, typically with specific type of Schedule 1 substances called psychedelics. And so in this talk today, I'm going to divide it in three parts. One will be a general introduction to psychedelics and how they've been studied in clinical trials, assuming that not everybody might be familiar with this topic, then move to how we can use state-of-the-art imaging techniques to understand how the substances impact the brain in both healthy volunteers, but also patients with psychiatric disorders. And finally, give an overview of how this field has been evolving, especially in older adult populations, where we see increasingly application in both late life depression, or an exploration at least for how these substances can improve symptoms in both neuropsychiatric and neurological disorders of advanced adulthood. And so I'm going to start with the first part now, which is what are psychedelics and why should we care? So psychedelic substances are naturally occurring substances that have been used since time immemorial across the world, and particular, here in the American continent, where they have been part of the cultural and medicinal use of indigenous populations for centuries, if not millennia. They entered, so to say, the Western world in the 50s when journalists and anthropologists, primarily from the US, traveled to Mexico and to the Amazonas.
And pause for a second there. One sec.
Oh. Right.
You're good to go. Sorry about that.
Okay, all good. You guys were hearing me all right before that?
Yeah, we're good now.
Okay, just here, general overview. These are substances that have been used for many years across the globe and have in the 50s entered, the Western world. So some growth, especially in clinical studies, looking at their potential for improving symptoms in alcohol use disorder, in depression, and then entered the counterculture in the 60s and were towards the end of the 60s and the 70s scheduled as a Schedule 1 substance by the Nixon administration, which stopped every research that was going on with these substances. We not only have naturally occurring substances, many have been also developed in the laboratory. Notoriously, Albert Hofmann, a Swiss pharmacist, developed LSD, for example, in the 50s and 60s, as well as other compounds have been, generated in pure pharmacological ways. And so we're talking about substances such as psilocybin, the active ingredient that is typically found in magic mushrooms, for example, LSD, which was, basically created by error by Albert Hofmann, also DMT, which is a very fast-acting psychedelic, which is found in some leaves, for example, from certain plants in the Amazonian basin. And these substances differ in many ways. Like, for example, the acute effects of DMT tend to be about 20 minutes, psilocybin about 4 to 5 hours, depending on the dosage, LSD up to 8 hours or even longer. But they have a couple of things in common, one of which is that they have a high affinity for the serotonergic 2A receptor. Here in these plots on the right, you can see the human brain. So we have here the frontal parts, here the mid posterior cortical areas, here the temporal brain areas. And you can see in this map that is mapping the density of the serotonergic 2A receptor through molecular neuroimaging techniques, where that these receptors are highly expressed in specific brain regions, which we call higher cognitive brain regions, which include indeed this posterior cingulate and precuneus, the prefrontal cortex, regions that are very, very important for higher cognition. And so these substances dock specifically to these receptors and are specific agonists activating the serotonergic to a receptor, which is the same receptor that, for example, many antidepressants work on, for example, SSRI, and so on. The other thing that they have in common is that they induce a very profound, depending on the dosage, obviously, but they induce a very unique altered state of consciousness, which typically involve perceptual changes such as hallucinations, synesthesias. People with eyes closed will see distinct shapes moving around, for example. If they have music, they will feel that certain tones will be associated with certain colors that will appear spontaneously in their, with eyes closed. But they also induce, at times, what participants and patients do refer to as a very profound psychological state, typically described with, effy words like a mystical experience, ego dissolving experience. Very often people are describe these experiences as being one of the most profound experiences in their life that include emotions or the experience of unity with the rest of the world and with a higher being, with themselves, feelings of insight that might resolve, for example, interpersonal or transpersonal, long-standing issues, as well as, a sense of awe in front of the experience that the substances can induce at times. There are also not always positive experiences associated with these drugs. As a matter of fact, actually, there are also certain risk factors for which we very carefully do screen in our trials. And it's not uncommon, especially at the beginning, in the first hour or so, for example, of psilocybin, to experience a heightened state of anxiety. These drugs do increase, for example, heart rate and in general sympathetic output. So it's very important that we screen for a healthy cardiovascular system. But also there are specific conditions that are risk factors for a worsening of mental health, which include a personal and family history of suicidal ideation or suicidal behavior, as well as a personal or family history of schizophrenia, bipolar disorders, and other disorders. So these are things, for example, that in general, the side effects that we see in clinical trials are relatively mild and include things like nausea and headaches, but also because we screen very carefully for these risk factors that might not be screened for when people recreationally use these substances out there in the wild. Nevertheless, psychedelics have seen an increased interest in research. You can see how since the early 2000s, the publication count of that include these substances has been increasing exponentially. And primarily because there have been multiple studies across very different clinical populations with distinct psychedelic substances showing that they can have a very quick and sustained effect in improving clinical symptoms across various populations. The first studies in this space were actually in the palliative space, where patients with anxiety and depression because of, term and end-of-life disease or terminal disease were randomized to, double-blind trials using the psychedelic psilocybin, showing a clinical betterment in the anxiety and depression symptoms of these patients happening as fast as the day after a single dosing session and being sustained for several weeks, if not months. This research from already 10 years ago has been, further developed with other studies with psilocybin being conducted in treatment-resistant depression. So these are patients with depression that have been already taking at least two distinct forms of pharmacological therapies that have not improved their clinical symptoms and for which psilocybin showed some improvement in clinical symptoms. So, resistant to therapy, that's what we're talking about here, as well as distinct, psychedelics being used in depression, showing across, this distinct clinical population, including now with MDMA and PTSD, and with psilocybin in alcohol use disorder, that we can improve the clinical symptoms across all these different populations. I will say that there are still outstanding questions. I'm going to go into this later on. One is that there are a subset of patients for which these drugs do not work. There is still a subset of patients that actually see a worsening of mental health. And there is the big issue for us as scientists to better understand how these substances work, because one of the big issues that we face is the issue of blinding. Very typically, we use either lower doses of the drug or even an inactive placebo as a placebo, but the blinding doesn't work because very typically patients and participants can very well as us, the researcher, by seeing their behavior, can very well guess what drug they were, which arm they were randomized to. So there is a big issue of unblinding, which I'm going to go a little bit more later on. So, a surge of interest in the substances in the clinical space, and a surge of interest also in better understanding how these drugs work on the brain. And so, yeah, here just an overview about, before I go into the distinct brain mechanisms, you can see how many studies are going on. These are 2 and 3 big clinical trials in mood disorder, existential distress due to medical illness, chronic pain, headache, and even other psychiatric disorders such as OCD, PTSD, and so on, which really highlight the importance of better understanding the mechanistic action of these drugs. And so there have been multiple pathways that have been studied, especially in animal models, one of which has been showing that these drugs can induce quick neuroplasticity in the brain. So we see, between distinct neurons, that the amount of spines, which are those little arms that the synapses that connect distinct neurons, are increasing after the administration of certain psychedelics. There is ongoing research about how these drugs affect social learning. This is related to the psychoplastogen model, with the idea that as the spines form, the time after the administration of one of these substances reflect an ideal time point to, for example, expose a patient or a participant to psychotherapy or to novel models that can be then learned and that can be then adapted in their daily lives, be this, to facilitate, for example, cognitive therapy or cognitive behavioral therapies. And then finally, also studying the effects of these drugs on the inflammatory system has revealed that they can have very quick and sustained anti-inflammatory effects, which, together might be some mechanisms by which these drugs can induce an updating of beliefs that very often is seen in clinical populations, where patients, for example, for depression, end up having a very different view of themselves and of the world that seems to be, in part, catalyzing the improvements in clinical symptoms that we see. And here, again, more in detail, so this thing, the model here, which has been coming primarily from animal studies, from preclinical studies, has been showing that these distinct drugs, whether it's LSD, DMT, or DOI, do change at the dendrites the amount of spines and synapses. And so we see this neuron growth, this increase in spine density, which can facilitate making new connection, especially depending on the duration of the altered state of consciousness induced by each of these drugs, which could then result in novel forms of learning. I might say at this point that there is still an ongoing line of research here about how important plasticity is in this context. Many other drugs do induce neuroplasticity. Neuroplasticity doesn't need to be always a good thing. It means only that the brain can be rewired. We're still doing a lot of research, especially in the animal models, to better understand how this rewiring and this, psychoplastogen model can be helped to rewire the brain towards a better, towards other forms of learning that can then, result in betterment of clinical symptoms. And there is still a huge controversy in the field, which separates primarily the animal scientists and the human scientists about how important actually the induced altered state of consciousness is, like the experience that participants have. People from the animal model tend to think that it's just a side effect of the serotonergic effects of the drug. which is, not important to predict clinical betterment. From the human side, there are camps that do think that actually what happens while people are under the acute effects of the drug are very important. Whether somebody is a positive experience or whether they have a negative experience will predict whether somebody, and especially how these experiences are integrated in the days after the dosing sessions will predict how participants will improve in the long term. And so, most of the things that I've been talking about right now are coming actually from animal studies. So studies in which rats and mice are dosed with these distinct compounds, where the effect of these drugs is observed in the animal model by looking how much they twitch the head, and where, after a couple of hours of day, the amount of plasticity and of anti-inflammatory markers can be measured with invasive method. Obviously, this is not, we humans are very different from mice just about the self-report of psychedelic experiences, as I just mentioned, can be one of the most profound experiences for many of our patients. And so we have been trying to use non-invasive methods, primarily EEG and fMRI, to better understand or to try to find proxies of how these substances work in the human brain. One very popular method is based on functional magnetic resonance imaging, fMRI, in which we measure the administration of oxygenated blood in the brain, or the supply of oxygenated blood in the brain, which we use as a proxy of underlying neuronal activity. And, a lot of the research in this space has been doing with what we call task fMRI, where, for example, somebody makes a button press and we can see activity in the left somatomotor cortex. In reality, our brain is constantly active also when we're doing nothing. So a method here called resting state fMRI involves having participants entering the scanner with eyes closed, and where we measure these spontaneous fluctuations in brain activity, which we can then use to map brain networks. You can see, for example, here these regions in yellow and in orange spanning the medial parietal cortex and medial prefrontal cortex can help us map the specific brain network, which in the literature is called the default mode network. And the idea is that these intrinsic spontaneous brain networks are constantly active and are constantly communicating and act as a scaffold for when specific tasks and cognitive processes need to be performed by us in real time. And so some research has been pursued here for the last 10 years by, for example, having healthy controls entering the scanner while they are under the acute effects of a psychedelic, for example, LSD or psilocybin, and by measuring their brain activity for 10 or 20 minutes, which has revealed that we see on acute under the acute effects, a disconnection between specific brain regions that are typically highly functionally connected. Again, this posterior cingulate and precuneus and the medial prefrontal cortex, regions that are very important for future planning, that have been involved highly also in symptoms of depression and other neuropsychiatric disorders, showing that under the acute effects, these regions tend to desynchronize. And this has been pushed even further, for example, in recent work where a few participants were scanned multiple times under the effect either of psilocybin or of amphetamine used here as a control, showing that some of the models coming from animal models, that the pyramidal neurons expressing high level of serotonergic 2A receptors, which here are spiking at baseline at a normal level, get desynchronized under psychedelics, and showing strong parallels between this desynchronization, what we see in the animal models, and the synchronization which we're able to measure under EEG. Here, for example, you see time series of EEG activity before any drug is administered, and here you can see how these time series get less predictable and more and basically desynchronized, which is something that we also see in specific brain regions overlapping with the aforementioned the full mode network, which is considered to be part of a system very important involved in rumination, in pleasure planning, in symptoms of depression, where we see this desynchronization and which overlaps highly, again, with the serotonergic 2A receptor. Again, bringing all these lines of evidence that these drugs act on the serotonergic 2A receptor, they synchronize brain activity under acute effects, and that this desynchronization is conducive to the creation or to the formation of new spines and to synaptoplastic processes. At UCSF, we're bringing, we are doing our own clinical trial, which we just completed, in which we have a highly personalized approach to this question, in which up to 8 participants with experience with these drugs were dosed up to 4 times in an interval of 1 week, and with a high dose of oral psilocybin, and who spend most of the time of the experience in the scanner, both before being dosed as well as after being dosed, and where we gathered also data about their experience while being under the effects of the drug, which we hope will help us better understand the dynamic of this desynchronization, of this complexity increases that we see in the brain, and how these changes in brain activity complexity do actually predict also longitudinal, not only what participant experience, but longitudinal betterments in patients. Which brings me to the next topic. The idea here is, as I mentioned before, that these drugs do, especially in the prefrontal cortex and in the hippocampus, might induce neurotropic factors, which which are related to the antidepressant effects, or which are conducive to the antidepressant effects that we see weeks after the administration of one single dose of psilocybin at times. And there has been some work here again showing that connectivity, for example, of the hippocampus, a region important in memory process, is changing substantially in the days after the administration of the drug, with the hippocampus also being involved, for example, in depression symptoms, as well as both functional connectivity, so how the prefrontal cortex is talking to other regions, as well as how the prefrontal cortex is structurally connected to other regions, changing after one single dose of psilocybin, with increased connectivity found after the administration of psilocybin, both for functional, in terms of functional connections, so how distinct regions are talking to each other, as well as in terms of structural connections, so how distinct regions are wired to each other. I believe I'm coming towards the end of my talk. I'll just, and of my time, I'll just conclude by providing an overview of what I think is one of the frontiers of psychedelics, namely their investigation in older adult populations. There has been already some work in this space, especially coming from UCSF, showing that psilocybin, for example, is, this is an open label study showing that psilocybin can treat mood dysfunction in Parkinson's disease. And as well, ongoing trials, this is from Johns Hopkins, exploring the effects of psilocybin in depression for early Alzheimer's disease. The idea here is that mood disorders, which are commonly seen at the initial stages of neurodegenerative diseases, are actually important predictors and important risk factors for disease progression. So targeting these mood disorders, targeting the anxiety and the depression that can be caused or that is associated with diseases such as Parkinson's and Alzheimer's disease, can actually have, if not a disease-modifying effect, at least a positive effect on the quality of life of the patients that can also improve the quality of life of the caregivers. We have been studying the effects of psychedelics in older adults through longitudinal observational studies. These are people that might go for their first experience, people above 50 and 60 that might go for their first experience out in the wild, showing that, overall we see improvements in well-being in older adults up to 2 and 4 weeks after they have this experience, and that these betterments in experience are particularly, these betterments in well-being are, at least in older adults, highly predicted by how socially connected they felt during those retreats or these, guided ceremonies that they participated on. So this is data comparing older adults to younger adults, showing that well-being improvements at 2 and 4 weeks in older adults seems to be mediated by distinct psychological mechanisms that what we would see in younger adults. And this has brought us, to this last slide, which is at the core of a clinical trial, which we're about to start in the summer. We just got FDA and IRB approval, in which we want to study the mechanisms and the safety of psilocybin in older adults with low well-being. We will gather markers of neuroinflammation, particularly TNF-alpha, but also baseline markers of Alzheimer's disease through plasma biomarkers to better understand how these modulate our primary outcomes, and where we will randomize our older adults to 4 distinct arms, either a high or a low dose of psilocybin or a high or a low dose of dextromethorphan, which is a neuropharmacological compound with similar properties to ketamine, a glutamatergic agonist, which induces an altered state of consciousness, but with a very distinct pharmacology than psilocybin. And we hope to use this design to improve the blinding, which has been a major issue in these clinical trials, and where we will acquire, neuroimaging before and after the experience, as well as some EEG with a wearable to better understand on the acute dosing days, to better understand both the longitudinal and the acute effects of these drugs on the human brain. And yeah, with this, I've come to the end of my presentation. Just here giving a sense for how long participants will be in the study for about 6 weeks, and we'll hope to also have a 3 months follow-up, and with multiple safety assessments looking at worsening of mental health and adverse events across the duration of the trial. So in conclusion, if I'd like you to take a couple, psychedelic substances are serotonergic to agonist receptors that are explored for their fast and sustained effects of clinical symptoms. And we're still trying to understand the mechanisms, which seem to be rooted on, neuroplasticity and anti-inflammatory properties of these substances. And while acutely the psychedelics might desynchronize the brain, specifically brain networks involved in symptoms of depression, rumination, and so on, longitudinally the effects of psychedelics seem to be focused in particular on the hippocampus, a memory relevant region, and the prefrontal cortex, and there is ongoing research in older adults. I hope that I was able also to convey both the importance as well as the limitation of the research that we're conducting, as well as an overview of the risk factors associated with the substances. And with this, I'm happy to take any questions. Just a quick acknowledgement of my colleagues and collaborators and of my funding. Thank you very much.
Thank you, Lorenzo. Any questions for the room? Thank you, Lorenzo. Oh, we got a question. Oh,
Lorenzo, what is the definition of an older adult?
We use the NIH definition. Typically, there is some variability. In our clinical trial, we will start enrolling at the age of 50. If you look at the NIH, it starts maybe with 60, 65. Since there is little research in that area, we went a little bit down with that age limit to start with a population that has already been participating in clinical trials. So just to start with an age where we know what to expect, for example.
You have another question?
What about the addiction aspect of using LSD and psilocybin mushrooms?
I love that question. So these substances have a very small liability of addiction. They do not act on the same neuropharmacological systems, such as, for example, cocaine, heroin, amphetamines, which target specifically the dopaminergic system. There has been a decent amount of research showing that the addiction potential of these drugs is very low. There are other risk factors, though, that need to be taken into account, which I mentioned before, which are in particular cardiovascular increases in heartbeat and in pulse, especially in the first half an hour of when these drugs are administered, which are relevant for older adults in particular, as well as a potential, state of anxiety or dysphoria that some participants might have for prolonged times, and that can induce a long-term worsening of mental health. Yet addiction on itself, it's not something that we have observed in the clinical space. Like it's something that even the FDA is not requesting from us to really systematically assess, because the risk is very low. They do not act on those same neuropharmacological system. In many ways, actually, participants would not want to have that experience very soon, since it's very, very different from what you would experience in your normal life. Yeah, I hope I'm answering the question, and I'm happy also to send literature if you are more interested on this topic.
Lorenzo, I actually have one question for you, sir. So just to dovetail on the earlier conversations we've had, we've historically focused a lot of our therapies in terms of neurodegeneration on protein pathologies, proteinopathies, trying to remove or extract or interfere with the cascade. However, there's a new line of therapies on their way through the FDA. Closest to market is the first neuromodulation device, Spectris device, that provides a form of 40 hertz frequency stimulation to the eyes and ears. One of our old colleagues at UCSF was one of the initial investigators of that over when he was working at MIT. Given that the evidence for psilocybin LSD potentially might be its capacity to augment network connectivity, and that there seems to be a new line of research and therapeutic interventions to change structural connectivity, interfere with the network as opposed to the proteins itself. Do you think there's a future with this type of research as a disease-modifying agent?
James, it's a very interesting question. I like to be very cautious in that space, primarily because, as I was alluding before, many other things do cause neuroplasticity. Like, if somebody's exposed to trauma, for example, you would see new synapses forming and new connections forming, which are then conducive to a worsening mental health. That's my personal perspective on psychedelics. I don't think that we have any data to support that the neuroplasticity effects can have a disease-modifying effect, nor in the animal models, not from human studies. That's one of the reasons why in this trial we hope to collect, or we plan to collect, plasma biomarkers of Alzheimer's disease to better understand how these drugs might modulate, or might interact with underlying neuropathological processes. If you'd ask me where to put my money, I think what these substances can do with their potential is primarily improving mood and well-being. Meaning, if you're an early stage patient with Parkinson's or Alzheimer's disease that is developing, or is suffering from anxiety, from depression, from whether this is caused by, you realizing that you're losing insight of your cognitive faculties, or whether it's because you got the devastating news and still have the insight that, oh gosh, I'm going to die of this disease that is going to destroy my brain, or whether it's maybe a product of the underlying neuropathological imbalances, which many models propose are causing changes in mood, especially in the context of Alzheimer's. I think that that's where these drugs have the highest potential, where they might improve the quality of life of the patients and of the family caregivers, which can slow down or mitigate the progression of the disease. And we have actually data suggesting this by interviewing patients that come to our memory clinic at the Neuroimaging Center, and which have been trying these substances out there in the context of, guided ceremonies, which now in Oregon, Colorado, and so on are very accessible, also in California. And, consistently, although it's a small data set, we see, it doesn't really change the symptoms itself. It changes how you relate to the fact that you have this terminal disease. And I'm not saying that people are just okay with it, but they learn to live with this and learn to live happily for a certain amount of time, and have their spouses and caregivers, live better with this. This is what has come out from our structured interviews with both patients and caregivers.
Fantastic answer. Thank you, Lorenzo. Oh,
Question
we have
over
one
here.
question? Oh.
Dr. Pasquini, quick question on the Siegel study with the desynchronization. That's obviously while someone's under the effect of the drug, correct? And so what about 24 hours, 72 hours later? I know this is a crude measurement, but do you see changes in synchronization after, you know, but more immediately after that acute effect?
Yeah, so this gets a little bit in the nitty-gritty of the measures. Let me go back to one of those slides here. This desynchronization that you see here on acute effects reflects an increase in complexity of brain activity, which means that if you have, for example, a highly synchronous time series, that activity is very easy to predict how it's gonna move and or how it's gonna evolve, and complexity would be low. On psychedelics, the time series of brain activity get more unpredictable, and so the coming back from signal processing models, the idea is that there is more processing of information by having more complexity in brain activity. When we think about longitudinal studies, these are, I'm highlighting here two or three that of you know a dozen or that have been published or so, not even a handful actually. We see that there is a reduction in functional connections between certain regions, particularly between the hippocampus and the posterior cingulate and precuneus, a reduction in connectivity within this memory important regions. It's unclear what they actually mean from a clinical point of view. The other thing that we see, though, consistently is changes in both functional and structural connectivity within the prefrontal cortex. The prefrontal cortex tends to be more connected to other brain regions on the days after an intervention, but also there is some initial data that this increases in connectivity doesn't just relate to functional connections, like how similar this activity in distinct brain regions is across time, but also how much stronger these structural connections are between brain regions. So in many ways, this paper here, which is in Press of Nature Communication, is one of the first showing through diffusion tensor imaging that looks at how white matter is changing and white matter paths, suggesting that there are some increases, especially in frontostriatal thalamic pathways, following one single psilocybin dosing session in healthy volunteers.
Thank you, Lorenzo. Any last questions? We got another question. Did you hear that, Lorenzo?
No.
How do you qualify for these trials?
So you're asking, well, it depends on the trial. You know, we have done trials in which we have, to better understand the mechanisms, dosed healthy volunteers that have some experience with these drugs, that have used them in the past. You know, it's not that uncommon here in California. For the clinical trials, very often you go through a very rigorous screening, and you know, I cannot reveal too many details, obviously, but typically we look at cardiovascular indicators of health, blood pressure, EKGs, because of the increase in sympathetic output that many of the substances can induce, and we screen for the presence of certain psychiatric disorders. As I was mentioning, family and personal history of schizophrenia, bipolar disorders, suicidality are things that we are particularly mindful of when recruiting. But then it depends on the study. Like, obviously, if you're doing a study in treatment-resistant depression, suicidality is, you know, something that is part of the disease. So it really depends on the clinical trial. But I'd say that the focus on safety at this moment is in particularly on certain cardiovascular conditions, primarily related to the acute effects, and then on certain neuropsychiatric and mood disorders.
Thank you. Any last questions? And that's it. Thank you very much, Dr. Pasquini.
Thanks for having me.